شكرا استاذ يحيى. السلام عليكم ورحمه الله. بسم الله والحمد لله والصلاه والسلام على رسول الله صلى الله عليه وسلم واشهد ان لا اله الا الله وحده لا شريك له واشهد ان محمدا عبد الله ورسوله. I'm really privileged to be among my professors and tutors. انا اتعلمت على ايدين اساتذتي من اول استاذ فهمي طبعا لغايه استاذ يحيى، مش زميل ولا حاجه ابدا، انا ابنك الصغير يعني. وطبعا استاذ سمير استمتعت بالمحاضره الرائعه الفيري ابديتد اللي تورينا ازاي انه الالدر جنريشن عارفين اكتر مننا في الابديتس. يعني شكرا لحضرتك، قامه وقيمه بيه. الحقيقه العنوان مجدي اللي اداهوني وبيدبسني كالعاده، كل مره يحطني في مأزق يعني. slowing down is an easy task, reversal is a very big issue and we cannot really control this so far. So let's move on, starting by where are we and what are we going to do. Of course, we all know that we have been transferred already from the diabetic nephropathy to the DGT, which is a new terminology. And as you know, the old stigma of diabetic nephropathy having only proteinuria and waiting for the microalbuminuria to appear, which is now A2, is not at all the right or the proper way to screen for our patient. That's why the EGFR was involved in the screening not to miss the ischemic type or the non-proteinuric type of diabetic nephropathy. We all know the structural changes and the GFR changes starting by increasing, and we have to be very aware of the single nephron hyperfiltration theory, because this is the mediation of how to slow down the progression of diabetic kidney disease. Definitely albuminuria and blood pressure control as well as the development of renal function is going on, and this is how diabetic kidney disease versus diabetic nephropathy on the broader terminology is appreciated, where in the pathway of diabetic nephropathy there is a proteinuria, and you have to differentiate whether this is a real diabetic nephropathy or a non-diabetic kidney disease in a diabetic patient. And we have privileged to have a paper on such work with Professor Iman Youssef in Alexandria, and we found more than 60% of our patients with diabetes having either non-diabetic pure or mixed diabetic and non-diabetic. And the primary disease that was associated with this was membranous nephropathy, which can give you very similar picture to diabetic nephropathy and proteinuria as well. Then the non-proteinuric pathway is the predominant ischemic pathway, where you have the ischemia and the glomeruli. And by the way, in this type, you would find the size of the kidney is smaller in size, not like the classical diabetic nephropathy, where you have a preserved or even increased size in the early phases. So how this implicates on the pathophysiology of the management. As you can see with this picture, it's very obvious that there is both tubular and glomerular changes. And if you look for the right-hand side, the glomerular changes started by the loss of the SGLT2 feedback, the TGFB or the tubuloglomerular feedback. And when this occurs, what happens is the hyperfiltration and the delivery of the sodium and the glucose to the tubules, which would lead to nephromegaly. And with the nephromegaly, it starts to have denudation of the podocytes from the basement membrane. And when this happens, glomerulosclerosis ensues, because almost always glomerulosclerosis starts from loss of the podocyte on the surface of the glomerular basement membrane. And this is a very important point. That's why maybe in the future stabilization of the podocyte and the nephron and avoidance of this loss might lead to reversal or at least complete arrest of the pathophysiological mechanism. On the other hand, when you go to the tubular part, you would see that in the tubular counterpart, the glucose and the sodium chloride need to be reabsorbed in a more and more efficient way. This leads to hypertrophy, and the hypertrophy would lead to nephromegaly. And as you can see, this ends up by the progression of the diabetic nephropathy. On the other hand, it ends by the tubulointerstitial fibrosis as well as the glomerulosclerosis. And this is the main difference between diabetic and normal kidney. On the right-hand side, you have small nephron with big number. On the left-hand side or the left panel, you have nephropenia and nephromegaly. So there are lower number of nephrons and increased nephron size. And this is mediated through downstream of this whole mediation of effects. And you have to remember that when the GFR is high initially with the incipient or hyperfiltration phase of diabetic nephropathy, this is not good at all. And when it comes back to normal without treatment, this doesn't mean normalization. This means loss of number with increased filtration for the remnant nephron. And this is again bad omen. That's why the tackle of diabetic kidney disease should entail the three mechanisms altogether. The hemodynamic mechanism, which we have been addressing for long time, and the metabolic pathway, which we all know with the glycemic control and the lipid control and everything else, and the recently known inflammatory pathway and the fibrosis, how to decrease this maybe with the non-steroidal mRNA. And just remember that hyperglycemia is not only immediate effect through what we have discussed by the progression of the metabolic outcome and the glucose filtration and the associated sodium chloride filtration, where you can block this by the RAS blocker or the SGLT2 inhibitor. There is also the late effect. And the late effect is mediated by many molecular mechanisms. And these molecular mechanisms have driven some of the authors to start to think about using anti-inflammatory, definitely not the classical anti-inflammatory, not non-steroidals, but using other anti-inflammatory, starting from the paradoxolone down to other mediating drugs like adrasentan and other, as we're going to mention later on. And this is the pathway that ends up by the podocytopathy, which we have just mentioned. And again, the aseptic inflammation and the metabolic memory, which we all know since the UKPDS study, and the legacy effect is now explained on molecular background, as you can see, with the metabolic cues and transcriptional changes that occurs. And that's why autophagy, mTOR inhibitor, and PKM2 can have a role here to stop the progression of this metabolic pathway. Of course, back to the biochemistry, we all know the polyl pathway and the aldose reductase pathway, and where the glucose abundancy can lead to the fructose and down fructose 6-phosphate and the glyceraldehyde 6-3-phosphate and the NAD-H imbalance, which lead to the age or the advanced glycation end products, along with the protein kinase C. And this leads to the TGF beta or the tumor growth factor beta, which leads to down fibrosis. So we need to block this pathway as well. That's why we can use ACE or RAS blockers. We can use control of the blood pressure by calcium channel blocker, or even by diuretic, or even by steroidal like MRAs, like in cases of resistant hypertension where you use spironolactone. We can use SGLT2 inhibitor, we can use GLP-1 receptor agonist and add on to control the glycemic pathway, and definitely we can use the non-steroidal MRA to control the fibrosis as well and the inflammation. So slowing down it's a fact, it's easy nowadays. We can speak about slowing down. We have many armamentariums, and they are not only the 3 or 4 classes of drugs that we know. First, don't forget the heat map. This have been posted since 2012, and it's updated in 2024 by the KDIGO. As you can see, people here are at moderate or high or very high risk of progression of CKD or DKD. They should be referred to nephrologist. They are at moderate or high or very high risk of progression of cardiovascular disease as well, and they should be monitored more closely. These are the 4 ways how you can read this heat map in its colors. And definitely the addition of albuminuria was very important, although it came very late, since the importance of albuminuria was appreciated years and years, maybe ages or decades back. But we know now that albuminuria leads to progression both for cardiovascular outcome and renal outcome. The more you have albuminuria, even in a recent paper just published a couple of weeks ago, even within the normal range of albuminuria, having an ACR of 29 is much worse than having an ACR of 10 milligram per gram, although both are in the territory of A1, which is a normal level. And these are the studies that have clearly shown that albuminuria is associated with poorer marker, and that regression of albuminuria using RAS or SGL2 or whatever can lead to lowering of the risk. As you can see, the hazard ratio here for different outcome. I like this figure very well because it entails not only the step ladder approach with the base that you have to go above lifestyle modification, lipid management, blood sugar, and blood pressure, and then the 4 pillars that we address nowadays, and we all know about the RAS and the SGLT2 and the GLB1 receptor agonist, as well as the non-steroidal MRA, but it also includes what we have just heard from Professor Helmi, where you precision medicine, where you go for anti-inflammatory updates in the management, maybe using some other drugs that can help even up to regenerative medicine in some situations. And these are the tips and tricks. Maybe we don't have time to go through the tips and tricks of how to use each of these and when to use and how to use the timeline for the development. Of course, we have after these flow study, the guidelines that shows in different situations that you should use the 4 of them, and the specific tips and tricks when to stop when you have hyperkalemia, when you have GFR decline more than 30 or 40%, SGLT2 inhibitor as per the glycemic state and the volume status, when to stop or when to readdress, because sometimes we are inclined to stop the drug, and when we stop it for good, and this is very bad for the patient. You have to re-challenge the patient, you have to reach the maximum dose or the maximum tolerable dose. And this is a very important slide. Although this is an extrapolation, but it shows very actively that with using both RAS and SGLT2 inhibitor as early as possible with a GFR of even 80 milliliter per minute, you can delay the progression of chronic kidney disease to reach end stage by 25 years. This can be up to 4,000 sessions of hemodialysis in the patient life. This is trillions of dollars for people with CKD. So the early institution, the persistence and experience of dealing with the drugs and with its potential adverse effect is very important. Of course, MRA, the non-steroidal, have been built on the residual risk, and this is the magnificent effect of non-steroidal MRA being an anti-inflammatory, not only in the kidney, but on the heart, on the metabolic, and in the retina, as shown by Professor Samir as well. And the good thing about this finerenone, that it entails most of our patients from a GFR of 90 down to 25, and from an ACR of 30 up to 5,000 or more. And the reduction of albuminuria was less than 31%, more than 31%, which ensure effective effect for a reduction of the outcome. Again, GLB1 receptor agonists we've just heard, and they are moving on, and many third generations are getting on, and the flow study have shown, even earlier study also Sustain 6 and Leader and Excel, all of them, they show the same benefit. Lastly, this is an unattainable target, unfortunately. Can we do something to reverse? Unfortunately, till now, with the JAK inhibitor, with the TGF-beta blocker, with the BKC inhibitor, with the endothelin, since the SONAR and the earlier study, we do not have the facility to block. Even with the autophagy that have been stimulated by different types of intermittent fasting, or even by drugs like sirtuin activators and others, all these have not been attained yet. And this is the holistic map for how you can try to attack. Pentoxaphylline have been tried in super maximum dose, more than 1,200 milligram per day or even more. The atrasentan have been tried in 2 trials. The pardoxolone is going back and on many times, pyroxodamine, and the pirfenidone that have a limited success in the interstitial lung fibrosis is not so far successful in the kidney fibrosis. The ropoxatorine and suldoxide and parsitinib, as well as a target molecular effect. These are the novel agents that are in the pipeline, and unfortunately, up till now, we cannot recommend any of these to reverse the effect, whether the advanced glycation end product that already happened, or the fibrosis that had already happened. So we are still lagging in reversal, although we have done very good in slowing down the progression of diabetic kidney disease. Thanks for your attention.
Thank you very much.